Tufan, I would love to discuss some patients and actual cases that I've encountered just to get your insights about how we might utilize urodynamics and how we might utilize urodynamic findings to help with management. The first case I have is this 62-year-old woman. And I think this is a very classic situation where she comes in to see me with mixed symptoms. And she tells me that she has both urgency and stress leakage. And it's very difficult to delineate from her history exactly which one. Sometimes she tells me she leaks without awareness, but her most bothersome issue is when she is active. So when she gets up to move out of bed, when she does any type of physical activity, she is extraordinarily bothered by all these symptoms. On her exam in clinic, she has some urethral hypermobility. It's a little greater than 30 degrees. And she did have a positive supine stress test. I didn't even need to stand her up to check. Thankfully, her residual was 0. And so we went through and trialed anticholinergics. We trialed beta-3 agonists. And overall, although it did decrease her urgency symptoms, she really had continued issues with incontinence that were not resolved. And what would you propose I do at this point with this patient? Is she someone that you're going to move to an advanced therapy for urgency? Or is this someone that I need to do something to mitigate what I saw in physical exam?
Well, thank you, Melissa. This is really a very common situation, very common presentation of urinary incontinence, namely mixed urinary incontinence. However, in this particular case, it's very difficult to classify it and to understand which one is the predominant one. Is it urgency or is it stress urinary incontinence? Although the physical examination clearly indicates the presence of stress urinary incontinence, I would still classify this type of urinary incontinence as unclassified urinary incontinence because the symptoms, the story that we are taking from the patient is not clear enough and maybe really misleading. So I think I agree with you. You did a great job with starting the anticholinergic treatment first. Because she obviously describing urge symptoms, but again, obviously she did not receive a great benefit from that. So at this point, before proceeding with any type of treatment, especially invasive treatment, I would like to see the urodynamic study of this patient, including a standard cystometry and pressure flow study.
How would you counsel patients in this situation? Like, what kind of information or counseling do they receive before you want to move forward with a multi-channel urodynamic study?
Yeah, thank you. This is a very important point because our patients, when they first hear about this invasive urodynamic study, they would like to understand why they are undergoing this procedure. Well, first of all, I'm explaining my patients that the urinary incontinence is not a disease, but it is a symptom. And different types of lower urinary tract dysfunctions can be hidden under urinary incontinence. I explain them briefly about detusser problems, such as detusser underactivity or detusser overactivity, and also the possibility of bladder outflow obstruction in that patient group, and how these findings will actually influence our decision-making and the choice of further treatment, and also how these findings may affect the success of their treatment, which they are undergo. So when they understand this, of course, they actually become very happy because it's every patient's right to know the exact pathophysiology of her symptoms, and also they feel more comfortable when they understand that they are undergoing pathology-specific treatments, not empiric treatments for their complaints. So I think these are the basic steps and basic points in my patient counseling for every patient, actually, with any type of urinary incontinence who are prone for a urodynamic study.
I would concur completely. One of the other messaging points that I give to my patients is that, we would like to be evidence-based. And so we need all the information possible so we can help make the correct decision first. Because obviously, many of the patients that we see have undergone prior interventions that have then put them at our doorstep with residual or persistent symptoms that remain extraordinarily bothersome or even worsened by the interventions that they've undergone. So putting it in the context of we need all the information that we can get in order to move forward with the optimal treatment strategy that they're going to define once we provide options is a very powerful way to message to patients too. So in this situation, I did go ahead with a multi-channel urodynamic study. Again, their uninstrumented uroflow was fine. They had a post-void residual of 0. And so as you can see on this study, they begin very early on at relatively low volumes to have low amplitude overactivity contractions. And this happens on a relatively rhythmic basis throughout the study. It's associated with leakage. It's associated with the sensation of urgency. But in addition, the patient, every time when we do an abdominal straining maneuver with cough and Valsalva, also leaks. And she has relatively modestly low leak point pressures of around 60 centimeters of water pressure. Then when we finally get to the pressure flow study, she has underactivity. Right? So this patient, although she can empty completely, doesn't give a robust detrusor contraction. So now I've got a situation where a patient has overactivity during filling and detrusor underactivity with complete emptying, as well as stress urinary incontinence. So what we thought was a complex situation has now become an ultra complex. How, with this urodynamic tracing and knowing her symptom bother, might you counsel her for the best next steps?
Yeah, this is really a very didactic urodynamic chart. As you said, there are different pathologies together. Sometimes we think it's very paradoxical to find detrusor overactivity with detrusor underactivity, but we have to remember that detrusor overactivity is a filling phase finding on the urodynamic traces, whereas detrusor underactivity is an emptying phase urodynamic finding. So they can be, of course, found together as in this particular case. And of course, you have to be careful here because this lady has detrusor underactivity. So if you are, if you go too much in increasing the bladder outlet on this lady, then she may easily have or develop urinary retention here. So it's a really interesting case. On the other hand, she has hypermobility as revealed by your physical examination. So actually, we need to find something that we can benefit from her urethral hypermobility, but also not to obstruct her. On the other hand, how are we going to explain this kind of phasic detrusor overactivity? Well, we don't know, of course. This may be due to a trigonal or urethral irritation or due to a primary detrusor overactivity. We don't know. But we know that in certain cases, if you treat these stress urinary incontinence successfully, then about 1/3 of these patients will also benefit in terms of detrusor overactivity and urgency. So, I mean, in summary, I would actually suggest a mid-ureteral sling operation on this lady, and I would be very careful to put it really as it is described, completely tensionless. I think this is very important. Another question you may raise, maybe, would I choose a transobturator or a transobturator or retropubic route? Well, I would go here for a transobturator route. I don't know if you would agree or disagree with me, because we know that the retropubic route is more compressive for the urethra, and therefore I would avoid that. And I would go for a transobturator mid-ureteral sling on this lady. These are my first thoughts, actually, about this case, Melissa.
Yes, I actually split the difference, and I chose a single incision sling for the same reasons, to try to avoid an obstruction postoperatively, and concur completely that in many instances, some of that urgency component will improve when urine stops dropping into the proximal urethra and provoking this response. I do counsel extensively, and I did counsel this patient extensively, that if her urgency component was not accommodated following the alleviation of her stress, that we may need to continue some of the medical therapies or even move to an advanced therapy at that time. So it was extraordinarily instructful for me to be able to interact with her expectations and what we proposed for our treatment plan to have this functional study available. She understood what was happening at that point, and made what I believe was a very learned decision with the information. We did a single incision sling, which she did very well. And most of her urgency component was relieved, and what wasn't was able to be accommodated for with a combination with a medication.
I certainly agree here with the choice of mini incisional sling if they are available, because they are not reimbursed all the time in every country. But again, the philosophy is the same, not to obstruct the urethra. But you have touched a very important point here about the patient counseling, about the possible treatments after surgery. And I think this is a very important point. And in the latest ICR, it is also very clearly mentioned that it is an absolute indication for urodynamic study if the results of the urodynamic study is going to or are going to affect your patient counseling about the postoperative treatment options. And again, I think the patient felt herself very lucky to have the opportunity to be informed about the possible treatment options in the future that she can face.